Mike Hindmarsh is, I'm going to introduce first, and is well known to Thunder Bay. I think the Valhalla is considering a suite named after him. We're not too sure if exactly the name yet, but we'll get back to you on that, Mike. So, he's been a strong support for us, having seen him in several presentations, supporting our attempt to innovate here in Northwestern Ontario. As the former director at the Clinical Improvement at the McCall Institute and president of Hindsight Healthcare Strategies, it's really a privilege to have him here talking about transforming practices in primary care. So I'd like a hand of applause for Mike Hindmarsh.
What I'm going to do is I'm not going to spend a whole lot of time on the front end of my talk in terms of a recipe for outcomes, but talk more about the benefits of the kind of change that needs to happen in primary care that I was discussing last night. I'm going to go through the recipe, and I'll just show it to you very quickly. It's up there. When we talk about change in primary care, the key thing that we need to remember is that we have to be systematic about how we go through our change. Much of healthcare planning in Ontario, in Canada, in the US tends to be very haphazard, tends to be very, well, maybe evidence-based, is not well studied. So there's an awful lot of health planning work that goes on for long periods of time, huge implementations happen, and then not really much changes in the system because we keep trying to tweak a current system that really can't do the job. The current acute care system is one that was born out of the First and Second World Wars, where the orientation was rescue the soldier, repair the soldier, and return the soldier to battle. And for the most part, that system does a very good job of handling short-term illness, injuries, infectious disease, those sorts of things. But with the burden of chronic illness that is coming, what we're seeing now is a very different type of patient. It's not a patient that, it's a patient that understands their chronic condition to a certain extent. They certainly have been living with it and have a lot of experience with it. They also have a lot of experience with their own lives, and that needs to be partnered with your medical expertise so that there really is a team approach to care. In the old model, the patient really wasn't very aware of what their acute problem was. They weren't able to self-diagnose. They were looking to you to fix them, and that model worked very well. But now we have to shift to a more collaborative type of care. What that means is that we can't keep pushing these very complex, sick people into an acute system that was designed for very short visits, very quick diagnosis. There was a pill or an intervention that worked right away, and cure was always possible. We need to actually build a new system, because if we keep trying to push people into this old system, what we're going to continue to see are the terrible outcomes that we see in terms of chronic disease care. In Ontario, less than 45% of people with diabetes are receiving the 4 basic guidelines of care: a hemoglobin A1C every year, a retinal screen, a foot exam, and a renal screen, let alone dealing with their LDLs, their blood pressures, and the other comorbidities that they come with. So what we're talking about today is how do we go about transforming the system? And this is the recipe that I want to talk to you about. There are 4 major ingredients for improving outcomes in chronic illness care and delivering good preventive care. The first, clearly, are evidence-based clinical change concepts. These are guidelines. You know them well. The question is, how do you use them? How do you get them into practice? How do you keep them at your fingertips? One of my early jobs at Group Health was to take our evidence-based guidelines and distribute them around through our primary care setting and then go back 6 months later and study how effective they were. The binders were about that thick because there was a lot of good evidence behind them. They were well researched. When I went back 6 months later, first of all, I couldn't find them. And if I did find them, they were propping doors open. So I asked the providers, what's the problem? And they said, well, first of all, we can't find them. And then second of all, we have nothing to keep our doors open. They actually weren't quite that glib. What they said was the problem was that they were too bulky, and to get to the care algorithms, they had to leaf through all this stuff to find what they needed, and they were never in the right place at the right time. So we thought, why not automate them then? That will make life much easier. So we automated our guidelines, put them up on their computer screens at their workstations, and they still never got used. The problem was it took 20 keystrokes this time to get to the care algorithm that you needed. So we just automated a dysfunctional system. So I finally, just before I thought I was going to get fired, luckily Our nurses in our system figured it out. They took the original binders, ripped out the care algorithms, laminated them, and stuck them up on the walls in the exam rooms. And that went further to implementing evidence-based guidelines in group health than anything else did. So the guidelines are an important piece of work, and quite often the simplest intervention can be the most effective. The next major piece is having a system change strategy. In this case, it's the Ontario Chronic Disease Prevention Management Framework. And many of you saw this last night. This, if you haven't seen it before, you will be dreaming about it over the next 10 years. It will crop up in your life when you least expect it, at family functions, weddings, all sorts of things. This will become your mantra for living. What the framework is saying is that we need to rethink how we design our care for chronically ill patients and for patients needing primary and secondary preventive care. The healthcare system needs to have self-management support happening at every encounter, so we need to make sure patients are doing good self-care. We have to redesign the delivery system so that it's not just an acute care reactive system, but it's also a chronic care and preventive system that is planned and population-based and proactive and reaches out to the community. We need to make sure that our providers are talking to each other and are fully integrated, and so that decision support is at your fingertips, but also your colleagues are at your fingertips, and you're all working from the same information systems, the same patient data, and the patients aren't having to tell their stories 100 times as a system. Healthcare organization, whether you're a FIT, a CHC, and a small practice, are organized around that chronic care delivery system, residing in a larger community that has a number of resources that you need to tap into. You can't be everything to all of your patients. You can't have exercise equipment in your clinic. You may or may not have people like educators, dietitians, pharmacists, but the community does. And so partnering with the community and making sure that patients get in to the community programs to support the treatment plan as well as the self-management work that you're doing with them is absolutely critical. All of that is leading towards a more productive interaction, and as I mentioned last night, what I hear time and time again from providers is that interactions with patients are extremely frustrating. And quite often they feel as if it's the patients that are non-compliant, they're non-adherent, they won't listen to what I say, but in actual fact, it's a system that is designed to produce a frustrating interaction for you. If patients come in with a lot of chronic disease and a lot of problems, they're still using a system that says, get in here in 15 minutes and get out. So what they do is they come with everything that's bothering them, and nowadays they come with all the internet material to support that they need you to read. But they see you as a scarce resource. They can't get to you very easily, so they want to make sure they get everything done in one visit. You, on the other hand, want to focus on what is really important for them, but you don't have the time. By the time you see a given patient by noon, you're probably half an hour to an hour behind already. So it's not a problem of patients that are non-adherent. It's not a problem of bad providers. It's a problem of a system that just doesn't support you. So what we're doing in this transformation work is helping you change the way you do care so that that productive interaction is one that at the time of the visit, both you and the patient are on the same page. The patient knows what the visit's about, you have the right information, the patient understands their condition and sees them as part of a team working with you, and critically sees them as the self-manager and the person that's going to take care of themselves. And that's a cultural shift. You know, one of the biggest issues that I hear providers say is, my patients aren't going to buy into this model, they want me to fix them. How many of you hear that from your patients, especially your older patients? Just take care of me. None of you? Oh, my work is done. See you later. I'll use my mother as an example. Shortly before she died, in her late 80s, she'd been seeing her family doctor for 20 years. And I was talking to her about self-management support and how we have to redesign the care system. And she said, yeah, don't talk to me about this self-management support stuff. Dr. Gabriel just fixes me. And I said, yeah, Mom, but you know, you're getting sicker and you're getting frailer and you can't expect him to fix all that because you've got to take care of yourself. And she said, don't talk nonsense. Dr. Gabriel tells me what to do, I do it, and that's fine.